Today's discussion provides a quick overview of the function, formation, flow dynamics, and blocks of CSF. What is the function of cerebrospinal fluid? CSF floats the brain. The brain will be crushed under its own weight. The brain will be crushed under its own weight if it did not have water to float it in. So that is the purpose of CSF. It also protects the brain and the spinal cord by providing a cushion around it. It distributes pressure evenly in the central nervous system. It also has a physiological role. It helps wash away some of the products of metabolism. CSF is not a static fluid, but rather it's a dynamic flow. About 500 ml of cerebrospinal fluid is produced daily, and at any time we have about 125 to 150 ml in the cranial cavity. CSF is secreted by choroid plexuses in the lateral ventricles from the arterial end. From the lateral ventricles, it flows through the foramina of Monro to the third ventricle, and thence through the aqueduct of Sylvius to the fourth ventricle. From the fourth ventricle, CSF escapes from the ventricular chambers into the subarachnoid space through the midline foramen of Magendie and the lateral foramina of Lashka. CSF floats up through cisterns, flows through the cisterns, and floats along the surface of the brain in the subarachnoid space to be absorbed into arachnoid granulations adjacent to the venous sinuses. Commonest derangement of CSF flow is blockage. This results in a condition called hydrocephalus, which can be defined as an increase in the volume of intracranial cerebrospinal fluid. There are two kinds of hydrocephalus broadly, obstructive and non-obstructive. You can classify them into four groups as obstructive, where the CSF is restricted or confined within the ventricles of the brain, and there is a block to the flow. There is a block to the flow between the ventricles or at the exit foramina, where the CSF is supposed to flow out to the fourth ventricle. This kind of an obstruction can be a congenital block, or it can be an acquired block because of some cysts, like a colloid cyst to the third ventricle, because of tumors which are obstructing the third ventricle or pushing the third ventricle up, or because of posterior fossa tumors. A block to flow can also occur because of blood clots. In communicating hydrocephalus, CSF flows through the ventricular system. It exits the ventricular system through the foramina Magendie and Lashka, but then the absorption is impaired. Why is it impaired? It can be impaired because the CSF viscosity is high, as in some tumors where there's an increased protein. It can be increased because of increased viscosity after meningitis, after tubercular meningitis. It can be increased resistance to absorption because of adhesions which prevent the CSF from reaching the arachnoid granulations. Rarely you also have hypersecretory hydrocephalus, which is classically produced by choroid plexus papillomas. Normal pressure hydrocephalus is a different entity which we will be discussing later. In Chiari malformation, also, there is an obstruction to the normal CSF flow. This results in two things. One, the cranial CSF can push the cerebellar pegs down to the foramen magnum, resulting in a cerebellar peg or a tonsillar descent and a tonsillar peg. It also results in CSF getting pushed down the central cord, resulting in syringomyelia. So hydrocephalus can be either primary because of a primary block, or it can be secondary when some other pathology results in a blockage of the CSF flow. Primary is mostly genetic, or at least 50% genetic. It can be either idiopathic or part of a syndromic. Associations of impaired cellular signaling and impaired development and proliferation are associated with the development of hydrocephalus. Some of the commoner associated birth defects include Chiari malformation, Dandy-Walker malformations, arachnoid cysts, and neural tube defects. Secondary blockages of CSF flow can occur because of infections, meningitis, especially tubercular meningitis. Hemorrhages, spontaneous, like an aneurysmal subarachnoid hemorrhage, might result in communicating hydrocephalus. Traumatic blood clots, they block the arachnoid sieves, resulting in increased CSF volume in the cranial cavity. Tumors can produce blocks. They can be anatomical blocks, that is, they are blocking one of the ventricles or blocking one of the drainage tubes of the ventricles. Or it can be just because of increased proteins secreted by tumors, which makes the CSF more viscous and less easy to absorb. For the purpose of understanding, let us divide the clinical manifestations of hydrocephalus into manifestations which are due to enlargement of the ventricles. The ventricles are getting large, resulting in a stretching of fibers which are moving around or which are curving around the ventricles. The first, of course, is increased head size. And if the fontanelle and the sutures are not fused, you will find that the head enlarges, classically found in infants and children, infants. The second is a distortion of the tracts or axon bundles which curve around the lateral ventricle. Cognition can be affected, gait disturbances can occur, and gaze disturbances like up-gaze palsy, which results in a classical sign called the sunset sign, might be present. Urinary incontinence also occurs because of neuronal or tractular distortions. The second group of features are features of increased intracranial pressure. This occurs early if the fontanelle are closed and the sutures are fused, obviously. There might be head banging because of headache. Papilledema occurs early in these cases, which can result in secondary optic atrophy and blindness. In infants, you can have bulging fontanelle. The sensorium gets impaired as the cerebral perfusion pressure gets diminished. There is a midbrain descent which can result in respiratory irregularities and other features. And the Cushing's triad of bradycardia, hypertension, and respiratory irregularities may manifest. How do we manage hydrocephalus? You have medication to decrease CSF production. Acetazolamide, popularly known as Diamox, and Lasix are often used for this purpose. Temporary CSF diversions might tide over a temporary block. For that, you use external ventricular drains. Intraoperatively, sometimes a lumbar drain may be used to decrease intracranial pressure. If there is hydrocephalus, this is often contraindicated because it might result in herniations. Permanent procedures for CSF diversion include endoscopic third ventriculostomy. This is classically performed in obstructive hydrocephalus and where the block is at the level of the aqueduct or of the fourth ventricular outlets. We are communicating the third ventricle with the subarachnoid space. Shunts can be used. Most common is ventriculoperitoneal, but ventriculoatrial and ventricular pleural are also options. What is a shunt? It's an assembly of tubes for draining cerebrospinal fluid from ventricles to other body cavities. So it has a ventricular end, which is passed usually into the lateral ventricle. This ventricular end is connected with a valve, which might be low, medium, or high pressure. And in a ventriculoperitoneal shunt, the valve is continued down as a tube, which is the peritoneal end, which is deposited, the end of which is deposited in the peritoneal cavity. Several special kinds of shunts are available. Bacterial resistant shunts are often used. These are antibiotic impregnated. We have programmable shunts where the pressure of opening of the shunt can be regulated from outside by a program. And so you can increase or decrease the resistance to CSF outflow. Anti-siphon devices may be incorporated into shunts to prevent variations in CSF drainage with erect posture or lying down. Shunting is a surgical procedure. It is associated with a small percentage of complications. Procedural complications can occur at the ventricle. There can be bleeding inside the cranial cavity, or the positioning of the shunt tube might be suboptimal. This can be minimized by using navigation and also conventionally by using anatomical correlates and by planning on the CT beforehand, before surgery. At the peritoneal end, rarely you can have bowel injuries. And occasionally, in an obese individual, the shunt may be accidentally placed in the extraperitoneal space. Later problems include overdrainage, where your planning of the pressure of the valve was probably faulty, and too much of drainage results in the brain shrinking and subdural collections forming, or maybe even a subdural hematoma. Underdrainage will result in persistence of the hydrocephalus. Blockage of the shunt tubes can occur, which can occur at the ventricular end or at the peritoneal end. Infections are a dreaded complication, and this infection might manifest as meningitis or it may manifest as peritonitis. Troubleshooting. When a shunt is blocked, we need to revise it if it is required. The second is exteriorization, which is a temporary measure, especially in infections. You can bring out the peritoneal end and drain CSF outwards till the CSF is clear, and a new shunt can be placed at another location. EVD also has complications, and so has ETV or endoscopic third ventriculostomy. EVD complications include bleeding and malpositioning, and endoscopic third ventriculostomy, which is a procedure where the floor of the third ventricle is punctured, might be associated with an incidence of bleeding. Earlier, when the equipment was not so good, there used to be a very high incidence of bleeding because you are puncturing into the space where the basilar artery and all the perforators are present. So this has been done under endoscopic vision. When it was done as a blind technique, there was a high risk of complications. So for a quick overview, the functions of CSF include protecting the brain, cushioning the brain, and buffering the brain from trauma against the bone. It also has a physiological role in the washing out of metabolic products. The CSF pathway starts at the arterial end in the lateral ventricles by the choroid plexuses. CSF drains through the lateral ventricles through foramina of Monro into the third ventricle, and from the third ventricle through the aqueduct of Sylvius into the fourth ventricle. CSF exits from the fourth ventricle through the midline foramina magenti and the lateral foramina of Lashka to the subarachnoid space, where it flows through the cisterns and then flows on the surface of the brain in the subarachnoid space to be absorbed by arachnoid granulations. The classical pathology is of too much CSF being present in the cranial cavity. This might be because of an obstruction to the CSF flow within the ventricular system when it is called an obstructive hydrocephalus. It might also be an obstruction or a relative obstruction which occurs when the arachnoid granulations cannot adequately and optimally absorb CSF, that is communicating hydrocephalus. We also have the entity of normal pressure hydrocephalus, which usually occurs in older people where the ventricle size is large, but the CSF pressure appears to be small. One of the reasons is that the pressure does not rise because cortical atrophy occurs because of the slight increase in pressure. Clinical features of hydrocephalus in infants, of course, you have an increasing head size. You might have a sunset sign. In adults, you have features of increased intracranial pressure. Normal pressure hydrocephalus is classically manifest as the Hakim triad, which is dementia, gait apraxia, and urinary incontinence. Management of hydrocephalus can be medical, not very effective, or by CSF diversions. This includes both endoscopic third ventricular ostomy, where there is an obstructive hydrocephalus, and shunts.